session we don't have enough chairs, and we're going to have 2 sessions back to back, so they're going to go for 15 minutes. So I can still see some empty chairs, so grab the chairs right now. Otherwise, you can get your 10,000 steps pacing for the next 15 minutes. With that, my name is Gora Dara. I'm the moderator for the next session or 2. As I said, we'll go for 15 minutes and then there'll be Q&A, so feel free to engage the conversation with them. I understand they have some demo, so it could be lively and entertaining. And we will have the speakers, there are 4 of them, so this could be an interesting session coming up. And I will be walking around and getting the HIMSS badges scanned in, so we want to keep a track of how many folks are attending each of the sessions, so kindly help me out with that. And because we have a long session, I don't mind if the speakers will come in and start introducing themselves, and then we can start on time at 11:15.
So we'll get the ball rolling, and we are going to introduce as we take our turns. I'm Raj, the third name. You probably have seen me before here, but this is all about the payers and providers coming to the table and talking about many facets of the organization burden and what we have done, what we are planning to do, what is the burden. So you're going to hear from the providers to start with, and then you're going to hear from the payer and what they're doing and their journey to get this process going. And then finally I'll come to, towards the end, talk about the collaboration. This is a 15-minute session, 50. Like after 20-25 minutes, you're going to see a 5 minutes demo, the recording piece that will tell you this is for real. This is not just a talk. And then you can think through the process based on what you heard. Towards the end, we'll have 10-15 minutes for Q&A. So with that, I will have Ben come up here and talk about the first part.
All right. Well, thank you for having me.
I can contact the slides.
Thank you for having me. My name is Ben Orwell, and I'm starting this off as a representative of the provider perspective in all of this burden reduction. I am a practicing pediatric intensivist at OHSU Dornbecker Children's Hospital in Portland, Oregon, and I'm also one of the provider informaticists at OHSU Health. And so I want to just start it off by talking about what doctors and patients are really looking for in this whole process. These are not a comprehensive list of all the things that doctors and patients want, but I think they represent some of the key aspects of the relationship that we can address with our burden reduction efforts. So number one, patients and doctors want equitable availability of the right and the best, maybe, tests and treatments for their healthcare problems. And healthcare, of course, is a time-sensitive process, and so people want to make sure that there are not unnecessary delays in the process of getting their healthcare taken care of. They want simplicity and efficiency. People have other things to do with their lives besides dealing with their doctors, and doctors have lots of patients to take care of. And then, of course, patients want to know how much this is going to cost them. And doctors want to make sure that they're getting reimbursed appropriately for the work that they do. So we want to have transparency in that process. And of course, there's a few barriers that we're dealing with in order to achieve these goals. One of the major ones that we deal with at OHSU is that there are many and varied insurance coverage plans and policies. We have a lot of challenges determining whether or not services are going to be covered and whether or not those services require prior authorization before they can perform. OHSU deals with dozens of different providers, payer systems, and they require a whole variety of different types of supporting information, and they have different types of coverage requirements that they're that they need for any particular plan and any particular patient. On top of this, we have a lot of antiquated or burdensome communication methods that we use to get through all this authorization process. Some of the more evolved payers have set up different healthcare portals and things like that that you can use to submit documentation, but I have it on good authority that there's a fair amount of faxing that still goes on. So, and then lastly, there's a lot of delays that potentially occur on the payer side in terms of making that determination and needing additional documentation and processing time in order to determine whether a particular service is going to be covered. So how do we deal with this at OHSU? This is a complex diagram showing the process that every outpatient managed care order goes through in order to make the determination of whether it needs prior auth and in order to get that prior authorization process. We have between 75 and 100 FTE dedicated to this process. And even though many of our managed care analysts are very experienced with the process at some of our major payers, this is still a ton of work, and this still represents a huge burden upon our system. You're not necessarily intended to understand or comprehend this entire workflow diagram, but I think it illustrates the complexity that goes into each and every one of these managed care operations at OHSU. So how can the Da Vinci Project and HL7 and FHIR help us with this burden reduction effort? What you can see here is that we've got 2 implementation guides that cover requirements discovery IG and the documentation templates and rules IG. Requirements discovery, of course, is intended to help us figure out whether a given service requires prior authorization, and then the DTR IG is there to help us figure out what particular supporting documentation is required and help us make sure that gets submitted and processed. What you see here is that we have arrows kind of going back and forth from both of these IGs to the provider as well as to the managed care analyst. And this is because at OHSU, we haven't yet decided that the providers are going to be the primary effectors of these, or interactors with these implementation guides. Some of the specifications in the IG suggest that the provider might actually do some kind of clinical decision support or other direct interaction at the time of ordering through a process, maybe involving something like CDS hooks. But I can tell you that from my perspective, from the provider perspective, I think that we've anticipated that we would experience a fair amount of resistance from providers actually to adding that step and adding that complexity to what can already be a convoluted ordering process in a busy clinic day. And so what we've chosen to do is actually to continue running all of this through our managed care analysts. And at some point, in our partnership with Cambia and MCG, and at some point when these things have evolved a little bit more and when we think that they're ready, we may end up putting them in front of the provider at the point of care again. So of course, in this whole process, there are some definite limitations, and the slide didn't quite come out formatting correctly, but opportunities over here. There are some limitations that we've had to deal with and need to overcome, and some opportunities, of course. So EHR support for FHIR is good, but not great. Many of you may have experienced this, but with many of the EHR vendors, they've improved a lot, but they're still not completely compliant with the FHIR specifications. And there are certain barriers to even getting apps and implementations in place within the EHR environment. But new rulemaking has definitely strengthened that process and made it more standardized. Additionally, healthcare data are really messy, and we know this. If healthcare data are not in discrete fields or are not in computable formats, then it makes the ability to process those data and have automated application of the DTR-IG a lot harder. This is a widespread problem, and any ideas that any of you have are definitely welcome. Fire itself is not perfect. There are a number of immature resources, and there's a lot of variability in how different data are encoded across different implementations. One example that I'll give from our experience is that at OHSU we have all of our procedures encoded using LOIN, but when we tried to interface those data with Cambia, they needed the procedures encoded in CPT. And there's no clear direct mapping between those two standards. So these are things that need to be worked out, but that's things like this and the HIMSS project are ways that we can work out some of these things collaboratively. And then, of course, lastly, I want to mention that there's competition out there. GHRs are building their own integrated systems of prior authorization support, and some of these systems may be more deeply integrated into the workflows of individual EHRs and compete with the open standards that we're trying to create here with the DaVinci project. And even though what we're doing is EHR agnostic, we have to acknowledge that the products that we're making have to be good and are in competition with others that are being done in this market where a few EHR vendors control a large portion of the market share. So, in summary though, from the provider perspective, I think there's reason for optimism. These burden reduction efforts that we're working on right now can only help in terms of reducing the burden on patients and providers in order to get the timely treatments and adequate reimbursements that they need. HL7 and DaVinci are, with FHIR, form a great foundation for continued work in community and standards formulation. And then I anticipate that government rulemaking will continue to hopefully improve standardization and accelerate FHIR adoption with upcoming final rules around payer-to-payer data exchange as well as burden reduction. So as I turn this over to Anna, I want to thank you all for your attention and look forward to further work with us.
Hot mic. Okay, here we go. I'm Anna Taylor. I'm from MultiCare Health System, and we have an accountable care organization that is called MultiCare Connected Care, of which we participate in value-based agreements, fee for value, with many payers, one of them being Regents, and that's who we're talking with about today. And the reason why, I'm going to just say this on top, Ben is saying agnostic of the EMR, is because we have to do this with many, many, many payers. And in an ACO, we have to do this with many, many, many providers. Not just one EHR, we have to do it with multiple. In fact, in our Medicare Insured Savings product that we participate in, which is the enhanced model, we have 11 EMRs of which we have to mine data out of and get to report quality measures on. So it is really important that we build an agnostic product so that we can be successful in a value-based space. Looking at the wrong one. Okay. So what about prior authorization? Let's talk about that. So as providers, we manage multiple workflows. Each one of those are unique, and they should be, because care to a human has to be unique for what they need to be. And so each of our providers and our authorization team manage all 18 payers that we have relationships with at MultiCare Connected Care in our value-based agreements. And in that space, there's a lack of standards. We don't do everything the same. Some of them you type in a portal. Some of them you fax a paper. Some of them you get on the phone, you're on hold for 45 minutes for one authorization. It doesn't work. Robots can do this, and we can get better. So there needs to be some sort of standard in our payload structures that makes us successful in doing this in a 1 and a 0, in a robot way, rather than a human way. The other thing is the capability of the EHR to enable standardized interop. And what that means is that we need to have the EHR and able to receive these payloads and put it at the point of care. It can't be buried in 8 clicks. It has to be right there when they make the order. It goes to the payer, it comes back, and it magically says, yes, no, I need more information. And that result can land right there with the patient in the room making it happen. So we have this standardized interop between all of our payers, meaning I only have to build one product for 18 payers, and I only have to build one product for 11 EMRs, then that is going to enable me to push my resources to our patients and not the administrative burden that we have within the administration part of prior authorization. And then this last point is to really say and repeat at the point of care where providers are. They do not want to move their workload. They don't want to be different. They want a magic wand that we call the art of providing care, right? They want to be able to be the doctor that they want to be. And so us as technologists and engineers and being in a provider organization need to enable them to do that. And so this authorization is not in a place where it does that today. And we can do that if we can make it into a robot and not a human. And then we push the humans to the more complex things that have to happen. So I'm going to talk about a little bit where we are in our FHIR journey and what we've done. We've put into place 2 use cases: data quality, data exchange for quality measures, and risk-based membership, which we call ATR. So data quality, data exchange for quality measures, we're putting in med reconciliation, which now I know what an 1111F code is, thank you. And this enables us to send our quality measures back to the payer in real time on a daily basis, so they know where we are and we know where we are in our quality measures, and the patients that really have a true gap are getting the care they need. So we are live on that right now, and we gave a talk on that yesterday, and we are seeing immense benefits making that happen. And the best one that I can brag about is the provider doesn't even see it. It's in the background, doesn't touch them. And we're giving better care to our patients. The next thing is risk-based membership. That's identity that we need to understand who we're responsible for in our value-based agreement. And if we don't know who we're responsible for, we can't care manage them. And so we have put into place a data exchange with regions that enables us to get that eligibility list using FHIR and an API. And when we serve up that eligibility list to the 18 downstream systems, we get a 95% match. That means my queue is only 5% now, not 20, not 15, 5%. So when we're speaking the same language, we're doing the right thing. We're eliminating that administrative burden. And then the last thing we're working on, which will be going into production shortly, is the prior authorization, which is what we're here today to talk about. And I think Ben really covered the points, the main points, and I think some of you know and experience the pain of prior authorization. And I think it's been valued at a $2 trillion problem in the US. And so I say to you developers, help us solve this, okay? And then the next thing I wanted to talk about, which I already went over, is some of the results so far. And this is the numbers. So production since September 2020. This is the ATR. This is our 95% match. We went from 80 to 95. And future, we're going to start using the bulk call to make that happen. And we'd really like to pitch it up to an EMR and be able to go soup to nuts, API to API to make it happen. Right now, we catch it with our own special sauce, but we are really excited to be able to do that in the future. And then data exchange for quality measures. What we're seeing right now is we were at a 24% compliance on that one, and now we're at 62 to 66 because we can mine the data better. We can speak the same language to our payers. we can improve covering those gaps to make it happen and really push that resource to the patients who haven't gotten the reconciliation. And we all know an appointment, 7 days discharge, improves all outcomes for that patient. So we have to make this happen. Really important, we'll be scaling to more measures, breast cancer screening, colonoscopies, and then the one that I call world peace, diabetic eye exam, because that one needs a lot of codification. All right, and then the next thing, what are we expecting out of prior auth? We're expecting to reduce the burden on the authorization team. So the authorization team and I went through, all right, how long does it take you to do one auth with this particular payer? And it's approximately 15 minutes to an hour. So that's huge span because every human is special, unique, and different, and every authorization needs special, unique, and different things. So somewhere in this span of 15 to an hour, we are going to reduce that time if we can do it in a click. It's pretty powerful, especially to the provider, because that authorization pile is never ending. We're not taking away jobs. We're getting the people what they need right away and pushing the complex stuff where it should be in a human brain. The other thing is that it's going to decrease our volumes by 8% per week for this payer partner. So that volume now becomes codified, and we then give more space for those complex things for the humans. And then the patients. I mean, that's what we're all here for. That's why I'm in healthcare. It's because I want to make it better. We all need health. It's a currency, and you can't use money to get it. You have to give it, you have to make it happen. And so we are really looking to reduce that soup to nuts time to our patients to make that happen. And we really believe this is a part of that process, is getting this authorization in one click. All right, thank you guys. And I'm going to hand it off to Heidi, who's going to talk about the payer side of prior auth.
Thanks, Anna. So, my name is Heidi Kriz. I'm the Assistant Director at Cambia Health Solutions, which also encompasses Regents, which is a Blues plan. Regents serves Oregon, Washington, Idaho, and Utah, so we've got members in all 4 states. In 2018, our CEO at the time wanted to really flip prior authorization on its head. As you just heard, it causes a huge amount of abrasion, it's administratively burdensome, and it's not timely. So we had a leadership group that was formed, and in 2018 we kind of set out our path and our journey and our vision of what we wanted to accomplish. So it's really exciting for me to stand on this stage because it's been years of work in the making. This is a visual representation of our vision at the time, which was we were getting a lot of faxes coming in. It was very manual, it was slow, and not ideal. So we knew we wanted to get into an electronic authorization workflow. We knew we would do that outside the EHR to start. So we have a workflow through Availity right now that our providers use. Right now we have about 76% provider adoption. There was a lot of work that's gone in the last few years to really get our providers engaged in this workflow and get them away from the fax. After the fax channel and getting them into that electronic authorization workflow, our next goal, which is hopefully happening very soon here in the next few weeks, is now to shift them into that EHR interoperable workflow using the Da Vinci FHIR standards. We're rolling out a pilot, as you just heard from OHSU and MultiCare. Those are our 2 pilot providers that we will go live with hopefully next month. When you look at this workflow and you shift from the left to the right, what's happening in more of the e-auth outside the EHR workflows, there's still a fair amount of manual human engagement in that workflow. So humans have to do a lot of clicking. They have to choose the clinical requirements for each of the policies during that prior authorization process. What we want to do now with this EHR interoperable space is be able to actually automatically put up the policies and automatically grab the clinical requirements that we need. And you'll see a demo of that here in a second. After that, what we've also done is built some artificial intelligence models. We have a lot of claims information, so oftentimes when a prior authorization is submitted, we don't get the right clinical information the first time. We have to pen the PA, we have to go back to the provider, we have to call, we have to fax again. slowing down the process. So what we're really hoping to do is use artificial intelligence to further drive some of these different rules engines and these workflows. So if we don't get something the first time, we can actually use artificial intelligence, mine our claims data quickly, and then also get to hopefully an auto approval. Our goal at the end of the day is to auto approve as many PAs that are coming in as possible. Then we do targeted audits on the background. This is our interoperability roadmap as an organization. As I talked about in 2018, we launched our electronic authorization workflow outside the EHR. This is absolutely foundational for us because what it allowed us to do is we built rules engines for what requires a PA, and then also we have an eligibility check that happens as well. So we can get both those done. We actually built out all of our policies with all the criteria involved for each of those codes, so that when a code goes in, we can surface that policy and the criteria. So that took several months in the making. From there, we knew we wanted to use FHIR standards. We wanted to have a direct FHIR-to-FHIR exchange with our providers. So we built up that expertise internally. We are founding members of the Da Vinci Project and have been heavily engaged in the IGs. We had a lot of conversations about what to build internally and what we were going to use externally, and you'll see some screenshots here. We did do our CRD is internal. We're using MCG, who you'll hear from Raj here in a few minutes, for our DTR piece of the phase of the workflow. And then we have our own provider dashboard for the PA submission, and then the providers can check the dashboard for the PA status. We needed our providers to collaborate with us, and so we had a lot of conversations, and we have a framework which I'll present here next on selecting our 2 pilot providers. We also knew that Epic had the majority of our members were seeing providers that used Epic, so we knew we wanted to start with Epic first, and then we'll kind of move from there to other EHRs. And then lastly, just a large business impact assessment, and then getting project management support. Prior authorization is complicated for the providers. It's also complicated for the health plan to run it as well. Lots of different teams are involved. Lots of different decisions are happening, and lots of different systems are interacting with those processes. And so we had to get all those different teams represented into the table and commit the staffing to make this happen. This was our framework that we put together in deciding who we were going to engage with first. We needed to have a strategic relationship with our provider partners. This was going to take time. We needed the staffing and the commitment from those organizations. We wanted providers that were innovative in their thinking and had a culture to innovate and come to the table with us. And then the next one is really important. We needed a provider that had the capability to come to the table with us from a technical perspective to get that interoperability connection. And then we're presenting on prior authorization. You heard Anna from MultiCare talk about other use cases. We wanted providers that had a value-based arrangement with us. So prior authorization is one use case. We have a couple other use cases we're doing for providers within those VBAs, and we wanted to take full advantage of that. These are the steps that we took to develop this workflow. So first and foremost, and probably the most important, was we came to the table with our 2 pilot providers and their office staff. So their staff that submits these PAs on a daily basis. We had conversations with them. They documented their workflow, what requirements they needed to meet, and then how we were going to hopefully automate as much as possible for them. I would say when you see the demo, our MVP isn't populating as much as we'd like. We have several enhancements we want to make to get more population for them. We also had to document our own workflow. Like I said, on the payer side, it's just as complicated on the provider side. So we both documented our workflows. We figured out what was the ideal situation for both of us. We developed wireframes and then all looked at those and signed off on them before we went to go build. We are in active testing right now, so we're doing end-to-end testing. Our providers are getting ready to start doing their end-to-end testing, and we're hoping to go live next month or in the next few weeks if possible. And then the last call out here on number 6 is just the provider workflow implementation. So obviously, once we build it, we've got to get the providers to adopt it. And so I say this over and over again, we've got to make this really good so that we can get the providers to use it. They want to use it, and we've got to shift them now to this workflow. This is a picture of our SmartAuth app. So what we did is we published our SmartAuth app in the Epic App Orchard. This is how the providers make that technical connection to us. It is direct FHIR-to-FHIR messaging. A lot of people will ask me about the X12278 regulation. We actually did get a waiver from CMS to be able to do this. What we're hoping to do is this is available in Epic, and then we'd like to publish our SmartAuth app into other EHRs as well, and then start to scale from there. This is a high level of the workflow, and then I'll go to the next slide and dive into a little bit deeper. So what you can see here is you have your EHR, you've got the SmartAuth app, how the providers are connecting to us. We're using FHIR standards. When the provider has somebody in their office and they want to do a service, they have to see if it requires prior authorization or not, so they know if the health plan is going to cover it. So the provider can go in, enter the code, we'll let them know right away if it requires prior auth or not. Then from there, we drive them over, if it does require prior auth, to the MCG tool, which is our DTR phase. We surface the policy criteria, and then based on that policy, we can codify it to pull the clinical requirements out of the EMR at that point in time. And then the provider has full administrative capability to take things out, add to it, or make any changes based on what the system automatically did. They hit submit, and then it comes into us. And then, as I mentioned, we have several rules engines firing, so I know if the policy criteria is met based on what they selected is applicable to their patient. We've got an artificial intelligence rules engine firing as well, and then between the two of those, we have a finals rules engine that hopefully will drive as many auto approvals as possible based on the information submitted. And then the line on the bottom here, we're also actively working on surfacing PA information to our members as fast as possible. So I'll just take you through this at a little bit lower level here. So you have the provider workflow on the left and then the payer workflow on the right. So when the provider wants to conduct that service, they'll send the CDR request, comes over to us as the payer. And then, like I said, we'll do an eligibility check, we'll do the PA check on the code. We have the member's information, we know if they're on our health plan and they're eligible for that service. And one of the things I like to call out in CRD that's really important is what we're seeing is about over 50%, sometimes upwards of 60% of the codes that the provider puts in actually don't even require prior authorization. So if they wanted to, right there with the member, they could just do that quick first step and know that it doesn't require prior authorization, and then just move forward with that service, which is, I think, one of the more exciting things about this. If the code does require prior authorization, then we move into the DTR phase of the workflow. So the PA is triggering the MCG app to launch, which is allowing us to show our policy criteria and the clinical requirements for that. From there, based on the policy, then the app will automatically select the clinical requirements out and match it to the criteria as able. And then from there, the provider can actually submit the PA, and we move into our PAS. Once they submit the PA, it comes into us for decision making. And then we have a member dashboard that surfaces the PA decisions, and they can do a status inquiry at any time. This is a screenshot, and like I said, I'll show you a demo here in a second, but this is a screenshot of what this looks like. So this is a policy. You can see the criteria is on the left, and then on the right are the different data points that we're pulling out clinically. And then you can see when the box is outlining the criteria, that's where we've pulled the clinical requirement and matched it to the criteria itself. And then there's a date and a timestamp there. One of the things I like to talk about with this is the difference between the discrete data and the non-discrete data. So the discrete data that's coming in are things that we can pull pretty easily from the EHR. But what we're trying to solve for right now is those non-discrete data points. So like if somebody's submitting a genetic test to us, we need to know the family history often. And so those are non-discrete data points that are really hard to get to. And that's often what takes our staff the most time to review. So right now we're doing different test cases with natural language processing to see if we can identify some of those non-discrete data points. And then, like I said, at the end of the day, if we still don't get it or we can't identify it, if we can use AI to quickly mine our claims data and still approve something, we'll do that. This is a value slide, so just kind of showing the value of this workflow. So it gives transparent and actionable data to our providers, which in turn hopefully will reduce the member turnaround time for their decisions so they can get the services faster. We're reducing administrative burden by auto-populating as much as possible for our providers and auto-approving as much as possible. And then I think, as I mentioned, from the health plan perspective, what's important is we see PA as just kind of the foundation for us for interoperability. Once we get that connection to our providers, there's so many more use cases we want to implement, so much more we can do. And you heard some of that from Anna on closing care gaps. Yeah, we'll go one more. Okay, so here's the demo. I'm going to just kind of talk through this. Is it okay? Okay. Okay, so we're doing the patient lookup where this is the anesthesia. They're going to go in and they're going to select the payer. Then they're going to go in and select the provider. And we have an active lookup for our providers. So once you put the name in, it'll identify the provider and auto-populate the demographic information for that provider. Now we're putting in the place of service. They're entering in the CPT code and the diagnostic code for that particular PA. And then we say that it requires prior authorization. So now we're going into the actual criteria here. So here's the policy with the criteria on the left, similar to that screenshot I just showed you. You can see the highlighted box. We were able to pull out something from the EHR that was applicable to that criteria. So it's auto-populated. Now what's happening is the provider can actually go in and select the criteria that's applicable to that particular patient. And then after they select the criteria, I have logic in the background. I know if that criteria is met based on what's selected. So that's my first rules engine firing to drive towards an auto approval. After that, they can choose to upload any sort of additional clinical documentation that they want, which is what's happening right now. They don't have to do this. We have an expedited review box if it needs to go quickly. So right now what they're doing is reviewing the PA that they just filled out. And then they submitted it to us. We're moving into PAS now. So that is showing that the PA right now is pending. This is Clinical Care Advanced, which is where we load all of our PA cases. And you can see right there actually in the middle that the case was auto-approved. So it actually already approved. Now we're going into our dashboard. This is the provider's view of the dashboard. This is the summary of the PA that was submitted. And then you can see on that top row, it just went to approved. So we communicated back. Now they can see that that particular prior authorization is approved. And then this is a list of all of the prior authorizations that they may have submitted to us in the status. I'm going to turn it over to Raj and he'll close us out.
Thank you. Probably some of you are asking that this feels like we are filling the whole portal application. What is different here? One of the challenges right now with the EMRs, right, they're still adopting these implementation guides from HL7 DaVinci. So what you have seen here, the pieces that they're entering in this demo, they don't need to enter in the future. This information is automatically captured based on the order request from the EMR, and then it goes automatically to the payer eventually. So in absence of the support from the EMR, we have created this modern fire app with Cambia. But some of these screenshots I'm just scrolling through just to show you the work that has been done. So the piece that is really cool here is that when they have submitted, instantaneously they get from the payer a status saying that here is the certification number and it is pending. Right? And the next thing that what they can see in the EMR workflow, the status is pending, and they can at any point of time, they can click and see what happened to my case. So when they click the details, as Heidi showed, it is already approved because payer has configured the rules behind the screens. If the criteria is met, and if I have all the information I need, I'm willing to auto-approve. So that approval information instantaneously populated into the provider dashboard. This happens within a matter of sometimes 10-15 seconds. And it's so cool that sometimes by the time they click submit and they come back and see the status, it's already approved or they're asking for additional information. That is the work we have done. So when you think about automation using HL7 DaVinci and the implementation guides, our real goal in the future is we don't want the providers to even submit all this information through the clicks. We want to go from the moment they order an EMRI or something, and they get the notification. Our vision is to go from the provider, they submitted the order when the patient is at the care, and they wanted to see what happened to the order from the payer. That is where we are planning to go from the step 1 to the step 4, and we have these two pieces in the middle. Right now we are automating those steps, but the goal is as we learn more, we go from some of the cases from the first step to the fourth step. In the same way on the payer side, once they get the request, they have a lot of processes in place today. They have multiple systems they have to populate that information, get the decision. We wanted to automate a number of their steps on their side as well, so that once they get the request, they have the rules engines in place, they have the artificial intelligence models in place, that decisions can be automated as well. So when we think about automation, we think about automation at every step, but we have to consider where they are today. You have to take what they have today and use the technology, the implementation guides, step by step, and you automate, and you reach to that nirvana place, right? So, as I've shown you this multiple times in presentations, it is a bridge between a provider and payer. And the bridge is going to take some time to build, and it built based on the trust, right? As you see, the providers and payers are here, their willingness to work through the automation for the patient care, for the improved patient outcomes. So what MCG does is it creates the platform, as you see in the bottom screen, the authorization collaboration platform. And we use technologies, we use rules engines, we use our evidence-based guidelines. They all help the patients eventually to get the decision in a much quicker time frame. And it helps the providers and patients, the payers to come together. The bridge of trust is that we work with them over the months and years. As they mentioned, that they look at every process they have, and we come to the table and say, what can we automate further? What are the other steps that you're doing manually that we can automate further? So that's what the value we provide. We use the rules engines, we use the automation capabilities, we use the technologies to achieve that. So that's our presentation. I would like to have 10 more minutes to see if you have any questions for all the folks here, both payers and providers. So if anybody has a question, please come up. Yeah. Any questions from the audience? For both providers and payers?
Thank you so much for your presentation. It is so needed to ease that burden and also be easier for the patients in that experience. One of the things that I have a question about is when you start to analyze that data, so that workflow of the prior authorization all the way through the receiving of service, because as you have refined and made the workflow more efficient, how do you then start to analyze that path along the way? Yes, I'm wondering where you house this type of data. I know that you're pulling it back into the electronic health record and into your systems that you're working in. I'm trying to figure out if you have an analytic platform in which you're starting to analyze that data in that process.
Okay, so she's asking how we're analyzing the data. So we, out of the clinical care advanced system, we have a reporting team. So we know what's happening in that CCA environment. The screen went by really fast, but it has all the information there. And so we're pulling active reporting out from CCA as a payer. So I can see all the policies that are getting used, which providers, I can see how many times they're auto-approving, how many times they're pending. Then we also have a report that pairs on top of that for our audit. So we're auditing auto-approvals actively as well and following up with those providers. So I've got that report. And then there's another report actually at the front end that's showing us how many times people are accessing the workflow and then what code they're putting in and when it requires prior auth and when it doesn't. Does that kind of get to the analytics? Okay. And then on the AI models too, I mean, I've got several Reports. The AI models also, there's active reporting coming out of those because we've got 3 different rules engines firing along that process to try to drive those auto approvals. So I've got reports on each of those engines and then who's making the final decision. If it's the AI model, the human, the product here that you just saw. So I know what's happening there as well. Lots of data.
Any other questions?
Okay, so my question is for you as well. So yes, I can understand auditing the approves, which totally makes sense. But do you also audit for false negatives?
Yeah, so we, and all that reporting that we just talked about, yeah, we're auditing everything. So I know exactly what's happening. And actually what's been really awesome is with the AI models, I can actually use AI to audit our humans a little bit and vice versa. So we're auditing both ways, approvals. We're looking at things that don't approve and why they're not approving so that we can take a look at our AI model as well and try to retrain it if we need to. So yeah, it goes both ways for sure. So, yeah, so in the EOF portal, we haven't launched obviously this workflow yet, but in the EOF portal, she's asking the percentage of approvals that we're seeing. So in our EOF portal today, we're averaging, it varies a little bit, but about 50% or more auto approvals. I have rules engines that fire, so certain policies are never going to auto approve. So we're never going to auto approve a varicose vein request. We're never going to auto approve a bariatric surgery request for various reasons. And so that's on eligible policies that we've said, okay, we're okay letting this one go and auto approving it.
Thank you. Great presentation. So on the payer side, you had an opportunity to work with a couple of providers, and you watched the fire, the implementation. Did you observe some of what you see challenges with implementation, where implementation is driven by interpretation? Were there some aha moments in gotcha where experience, having gone through this, where testing and certification and what tools you might need for wider adoption when you're looking at literally hundreds of provider organizations onboarding? Have you gained any insight? Have you gained any experience that you share with everyone? I'm talking about, like, each of the providers has their own experience, but the payer is going to be seeing dozens of different types of providers, and they're all interpreting it in a slightly different way.
So, good question. I think because we've had our EOF workflow through Availity in existence for several years now, we have experienced everything. So every provider, as they've talked about, is different. Their workflow is different. Their staff's ability to submit those PAs is different. So through the EOF work that we've already done, it's a lot of engagement with our providers. One of the reasons we have 76% adoption is because we had a really strong provider team that went out to really touch base with all of our providers. And yeah, I think the biggest issue that we have faced is that the staff submitting the PAs are not clinical often, and we're asking them to do clinical things. And that's where I think, having that vision of getting away from that manual human touch as much as possible and populating with the clinical data points in the Da Vinci workflow is going to be absolutely critical to truly transform prior authorization.
From the provider side, our 18 payers that we work on a value contract all speak a different language. Even in fire, they might speak a different language. So the challenge is, where do you find semantic interoperability? And that has been the one thing that might slow down an implementation for us, is like, okay, you're going to give me this in a fire payload, and the first name is this, and you concatenate it with the human name. And now we have to unconcatenate because every single system we have downstream does not concatenate first and last name or first and middle name, whatever. So it's not perfect. I would say it's moving up the maturity chain and pushing more of the simplistic tasks down
But the challenge we've had is still the semantics. And I think we run into that mostly in our quality measures too. When we're exchanging those using a fire payload is, okay, the same thing, mapping a loin code to a CPT code. In our CCDAs, we had to totally redesign those just to get everything to match together. So there's opportunities for semantics.
Any other questions? If not,
While people are thinking if they have any other questions, I'll just piggyback on top of that a little bit further, just in saying that I think that there are still a significant amount of limitations in terms of the fire spec implementation in, for example, in our Epic EHR, which obviously is very common around the country. You can't carry the context of what you're doing necessarily all around the EHR with you. And so, for example, when we were trying to figure out this procedure code situation, we actually not only couldn't map the loin codes to the CPT codes, but we couldn't even just choose the one procedure that we were ordering. The fire server would give us back every procedure that was pended for that patient, and we might have one, but we might have 100, and you got to choose which one you're actually trying to get authorized. I think there's immaturities in the smart authorization platform. What kind of things are you going to be authorized to actually see and do within the data that you're requesting? All sorts of these things are going to be important as we try to make these work from one place to another and actually implement them around the country. There was a long delay even in just getting the application approved to get into the app store to actually get us to be able to use it. And those kinds of things are just going to be further hurdles that we're going to have to work out as we try to do this more.
The other thing I was going to add too, what was interesting for us as a payer was we almost are kind of in a vendor position, so we actually have to do trading partner agreements with these guys too, and we didn't realize that until late in the game, so we're just finalizing that piece too, so that was kind of an interesting aha moment for us.
All right, folks, let's give a big hand to the team. They did a phenomenal job. Thank you very much. So that concludes this session. Again, the next session will be at 1:15, so come back in about 10 minutes from now. And as you can see, the seats are scarce, so please come early and grab a seat. Next session at 1:15. Thank you.